Time now for this week's Health Matters. Paul Critz with you, along with PA Lynn Szabo, host of Health Matters. And you brought debt with you today, huh?
Medical debt.
Ooh, the best kind of debt. Baggage, yeah. Medical debt. Okay, yeah. I guess it's something you really don't think about until you're strapped with it, right?
It's foisted on you, actually. Yeah. It's not like somebody's seeking it out at all. So medical debt obviously is debt due to medical costs. And it's a huge big deal in the United States because nobody ever really expects to stumble into it. But I think in the United States we have a little bit of compassion toward this kind of debt because, I don't know, somehow it doesn't taint your soul, really.
Yeah. It's not like going out and going to the casino and coming home in debt.
Right, you can't scold somebody for, having a gallbladder attack or something.
Right.
So it is definitely worse for people ages 18 to 64, which is kind of a bummer. And I wonder why 64?
Medicare?
Yeah.
Yeah,
absolutely. And most people with medical debt do have insurance. It's expensive to have insurance. You've noted that before. Medi-Cal, or AKA partnership, is definitely a better deal.
Yeah.
Because you never even see a bill.
Yeah.
I remember somebody in urgent care once accidentally got a bill because there was a problem with their partnership, and she brought it in to me to look at it because she was so completely horrified. She thought maybe they sent it to her just to guilt her up. But no, I'm like, no, a 4x4 piece of gauze really does cost $12.
It really, that's not surprising that it's most people, it's the people with insurance have the most medical debt. Because that's like insurance kind of sucks you in. We'll pay for part of it, and then you're on the hook for the rest. Whereas if you show up,
and they're never really clear.
Yeah, you don't know.
Pay for. And
exactly.
So it's kind of like you never really have a way to understand it up front. It just kind of magically gets laid on you.
Right.
So, and I've seen many, many people who forgo medical care solely because they're worried about the cost. And so what happens oftentimes to those people as a group is that they get sicker, and in the long run, their costs are more.
And because of insurance and the way it works, they end up driving the insurance costs up for everybody. Right?
Because Lord knows they can't possibly lose money, right? I mean, it's it's a bet, right? It's a bet that you're going to either stay healthy, or if you get sick, it's not going to be bad enough to be a big drain on their company. Insurance companies are some of the wealthiest companies in the United States. No surprise. And cost of care in the United States often double the cost of care in other countries, which I found like shocking. I mean, even though I'm super cynical about all this, I think that's shocking.
Double the cost. Okay. I mean, there's a whole episode there about why. Why
I think
is that?
Part of, if I had to guess on the fly here, part of it is care is not very efficient here. Part of it is you have to tick some boxes before you can get the test that's really meaningful that can help you diagnose. And a lot of it is rule out lawsuit. That's what we call it in the biz.
Is what?
You do testing to rule out lawsuit.
Oh, rule out lawsuit. Okay.
Yeah, it's because of lawsuits. And they're fortunately have that kind of under control in California, but they're not very common in other countries. So, but it's a huge, big ancillary industry here in the United States. And also cost of care in other countries is controlled by the government. For example, Canada, probably. But what happens in Canada, people get delays in care. Same thing with Great Britain. At their National Health Service, people get incredible delays to see their provider or to get testing that they need or to get treatment.
Yeah, and why is that?
The line's long, I guess.
Yeah.
If you're only going to allow so many dollars to be spent.
There you go. That's it. Yeah.
Then
you're hamstringing the system from the get-go.
It's a total toilet clog. Yeah.
a total toilet clog.
I'm
going to start using that. Yeah. Thank you.
Anyway, here's what really shocked me in kind of looking at this. Even declaring bankruptcy doesn't get rid of your medical debt.
Are there other kinds of debt? I mean,
Sure,
It gets rid of why
like
why
maybe your credit cards, maybe your I don't know
why does
department store bill or
who
new
decided
car.
who decided that well, I know that I know what other kinds of debts are, Lynn. Who decided that medical debt stays with you though?
I'll bet you it had something to do with lobbyists for the hospital industry, the laboratory industry, and the medical industry.
And the insurance industry, I would
the insurance
imagine.
industry too. Yeah, and it gets even a little clearer further on. I don't know, I don't understand why they have to be so draconian, or so horrible about it. Anyway, there's a few ways to avoid it. And of course, the top of the list is to upgrade your insurance.
So you're saying, okay.
So go for a smaller deductible. Go for smaller co-pays. Go make, some people, that might mean choosing to be double insured, although that's no guarantee.
So, I mean, it does seem kind of like, it's tricky to say, the way that you can avoid this debt is to spend more money.
Right. More money, but the money is directed more into the insurance industry instead of the medical industry. And even if you have two types of insurance, oftentimes both insurance policies are like figuratively pointing at each other to pay.
Really?
Yeah.
They argue back and forth like that. Wow.
Yeah, and they have bizarre reasons why it's not their responsibility. And then other sources of financial assistance, I'm going to choke on this one, is what we see all the time, GoFundMes.
Why does that make you choke?
Because healthcare is a right, not a privilege. And nobody should ever have to have a bake sale to fund a child's medical need.
Yeah. There's a whole critique of that whole sort of like economic subsystem there. That is, we pat ourselves on the back when we see a successful GoFundMe campaign, but really we shouldn't. We should be horrified. Yeah, because they had to resort to a GoFundMe campaign. Yeah, exactly.
Right. The other thing, which makes more sense to me, is, but it's hard to do, debt negotiation and really monitor bills when you get them to make sure there's no errors. So those are kind of two different things. First, you monitor your bill, and then you notice, for example, there, air quotes, an erroneous double charge.
Right.
And then so call them on that. It's really, really hard to do. It's a lot of, burns a lot of time. You have to be on hold for a long time. You have to argue with people. They have, usually you end up talking to somebody who has no idea what you're talking about and no idea how to fix it and no ability to fix it. But calling them on their errors, and there are a lot of errors, and I think they just rely on people not having the wherewithal to argue with them.
Right.
And then, but the other thing is that, you can, if you get to the right person, let's say, hospital billing, you can negotiate a bill. And I did that actually for my oldest daughter's birth. I negotiated them down.
Really?
Yeah, until I had a reasonable amount of money. That was in 1992, and that was a C-section delivery with a couple extra days in the hospital.
Oh, wow.
And so I always tell her I was able to get the pink slip earlier because I negotiated the bill down. But you can do that, and you can argue your point.
And it does seem like, and you sort of hint at this hierarchy of interaction.
Right.
Because you've got the person who doesn't have skin in the game, doesn't have the authority,
May
can't
not even
help
speak
you.
English. A lot of medical billing corporations are like in the Philippines. And
But
stuff.
if you keep going up the chain,
Right.
then you'll end up with somebody who can just wave a wand and make it go away.
Right. Or if you show up in the billing office, which is harder and harder to do with the paper in hand.
Oh, that'll get you.
Because face to face, you have to be respectful. I'm not saying you go in there and scream at people, but face to face is much easier. Don't talk to the doctor or the healthcare provider, because a lot of people come to us and we really have no control over the billing. That was the whole part of the point of electronic health records, that you can't really no charge somebody. Open Door in the early days was totally cool with provider discretion to no charge a patient.
Really?
And yeah. And I did it a lot until they kind of put the brakes on me. But, most providers are not really attached to the money thing. I know that sounds weird, but they have no idea how billing works. They have no idea who you should talk to. They have no idea how much the cost would be different from, one kind of billing click on the computer and another kind of billing click.
Right. And is it realistic to expect them to know these things?
Yes and no, I guess I could say. I think that providers should be aware of how they're putting debt on people.
Mm-hmm.
I totally think that's the case. But I also think if it was taken completely out of everybody's hands, the myriad of people's hands, and put into like a one centralized system, I think that would be so much easier.
Mm-hmm. Mm-hmm.
And then with some clear and honest instruction about how somebody can get questions answered or maybe billing changes if they see an error.
Mm-hmm.
But the whole thing is like smoke and mirrors.
Yeah.
Yeah, and it's really weird. I know, I guess it's greed and all that, but...
Well, you've got several points along the chain where somebody profits.
Right.
And if you lessen those points...
Right. It's like the more confusion you make, the more profit there is.
Yeah, that's another...
And less confusion and less people holding hands out for money.
Right. Yeah,
the better. It's like buying a house. If anybody's ever done that, there's also a lot of hands being held out along the way.
Mm-hmm. And it would just be nice. I'd like to think of my healthcare provider as just being able to concentrate all their time and energy on being a healthcare provider, on being a doctor, on being a PA, and not being a billing person.
Like if somebody comes in and they blew their knee out at a Saturday soccer game, and I know that there's an internal derangement, which sounds very scary, but there's the joint is messed up.
It's going to be my next album, actually.
Yeah.
Internal derangement. That's great.
That's your code name. So, and I know that an MRI is the image of choice. Why do I have to, assign this person to an X-ray, which is useless, and for the most part, not always, but in 6 weeks of physical therapy, which you have to wait 6 weeks to get. And here's this young athlete, like having a huge mobility problem, probably a pain issue that we could argue is not adequately addressed, and he's got a hurry up and wait scenario.
Yeah.
With maybe a worsening problem.
Right.
Because it was intended to. I mean, we know the data tell us that. Mm-hmm. So it's so hard to explain it, especially to an irate mother of like a 26-year-old male athlete, usually, why her baby can't get an MRI this afternoon, and I don't believe that should be the case. Mm-mm. It's not what I think is good medicine.
No, if it's medically necessary,
right?
In your opinion, your professional opinion, if it's medically necessary, then you shouldn't.
And then she gets angry. The angry mom calls the insurance company, and the insurance company says, "Oh yeah, your provider can order an MRI of his knee," and they don't say. Yeah. And we won't pay for it because she hasn't gone through the proper procedures.
Seriously? Okay.
Seriously.
So they set it up then for it not to be paid for in that regard?
Yeah. But they also, they're kind of lying. They're disingenuous.
They're not giving you the whole picture.
Right. And so then angry mama comes back to me and says, "Why don't you know this?" And I'm like, I know I can order one. I know I can push it and get him in to be seen quickly, but it's $8,000. Are you guys okay with that?
Wow.
And then she so she forgot to ask the most important question when she called the insurance company. But anyway, it is possible to negotiate debt, and it is possible to consolidate debt to decrease interest costs, which I also want to choke on.
And and all the things that you've pointed out in here, I mean, upgrading the insurance, the other forms of financial assistance, the debt consolidation, debt forgiveness, all of that, it doesn't address the issue.
No, it doesn't.
No, it just addresses the symptoms.
No. And so the next thing is debt forgiveness. Mm-hmm. So it is possible for a big corporation to forgive a certain amount of the debt that's owed to them for tax write-offs.
Yeah, it's beneficial to them. Yeah. I had a credit card debt after a divorce go away for that very reason, and I was very grateful. And all I did to get to that point, this is my favorite debt story, I just said, I can't pay it. Right. I can't pay it. I'm living in my business, friend. I can't pay it. And they're all, okay, well, can you give us $5,000? I can't pay it, and just kept doing that and throwing away the notices. And then finally I got one that said, okay, well,
we give up on you.
We give up on you. Exactly. And I'm like, oh, credit ratings is a real toilet clog, but still, see, I got to use it.
But still, how did you get to that person that was able to even make it a little bit less?
I didn't.
Yeah. I
told them I can't pay it, and they said, well, let's sell you debt to another business that's going to try to collect. And I just kept telling them I don't have it. And then finally they went, okay, and wrote it off.
Yeah. You're not worth our time anymore.
Yeah.
So, but that happens with medical debt. There are nonprofit organizations, charitable in nature, who buy medical debt. And this is what kills me, for pennies on the dollar. Wow. And then just forgive it.
That's just like with the debt collection agency. We bought my debt from the credit card company, right? Same thing. Right. And then they just go, okay, there you go, vaya con Dios.
Yeah, then there's probably some tax thing in it. So in 2016, John Oliver used $60K to buy $15 million of medical debt. I'm
an avid John Oliver fan. I do not remember this at all. No.
Yeah,
wow.
I didn't remember it either. And he did it through the organization known as RIP Medical Debt. So rest in peace, medical debt. Okay. And they target people specifically in circumstances probably not unlike your own that make it impossible for them to pay debt back. Mm-hmm. And so if I was to throw a $100 donation to them and get that written off my taxes, probably, they can use that to wipe out $10K of debt.
Wow.
So, and there is a legitimate nonprofit also inspired by Occupy Wall Street. Oh, this particular one is a legitimate.
The RIP medical debt.
Inspired by Occupy Wall Street.
That's
but
amazing.
My question is, why don't medical organizations just do that at some point? Why don't they just?
Because they're squeezing the consumers who can pay, who take it as like, oh, I've got to pay this debt.
Yeah,
they're squeezing those people to make sure they get as much money.
Trying to benefit from guilt or something, or fear of credit.
Well, and those people are paying, but they're not paying back pennies on the dollar. They're paying back dollars for dollars. So that's just going to be more for the insurance companies anyway. But bottom line is they don't need it and they can write it off.
Right. I think it's so incredibly twisted.
Mm-hmm. It's a sadistic system, isn't it?
Yeah.
Wow.
It completely is. You don't really have any control over it. It kind of lands on you. You can't really control how it comes out. You can't really, you're in a completely powerless position to argue about it. And eventually there's, I guess, a solution, which is completely bizarre.
Yeah. And coupled, and the bizarreness gets played up by the fact that your very debt itself, your debt, which is I look at it, it's a hole, right? It's a hole that needs to be filled. Your debt is fungible in and of itself, and they can sell that debt to other people. And there's a value to that negative value. There's a positive value to that negative value. That's how good we are at turning things into commodities. It's just amazing to me.
Especially medical care. I mean, there's such layers of it.
Right.
I had a personal experience when I lived in Denmark as a young adult, where I had to access medical care for a really minor problem. And at the end of the visit, I said, so where do I go to pay? And there were a bunch of doctors in the room. I could tell they were doctors because they had white coats on. Exactly. So it was super exciting that the English-speaking, tourist had this problem that was really easy to fix. And then as soon as I said that, because they all wanted to talk to me medically in English, right?
Oh, cool.
And as soon as I said that, uniform disgust that it was even like a topic.
Oh my God.
And I got a huge lecture in English, super cute.
Really?
Heavily Danish accent.
With the accent, yeah.
About how healthcare is a right.
Yeah.
And in Denmark, they see it as a right. And I have a right to be healthy. And there is absolutely no talk of money right now.
That's why they got to lecture you.
Remember, this is 1981. I'm not sure how things changed. And I went in with a minor problem, nothing surgical, although I did have a friend who had a knee surgery, same experience, all for free. So I'm not necessarily saying go to Denmark to get your health care, but why can't
And
Can't we do that?
It may have changed. I've shared this story before. A friend of
Right.
mine was on his in New Zealand on his honeymoon, fell off a horse on the beach and broke his wrist. And they kind of they fixed him up. They took him to the airport and they told him to go the hell home because he didn't get any more free medical care. American, take it home. Okay. And so,
Yeah, that's.
I wonder now if you tried in Denmark, if you'd be shown the door.
I don't know. Or just actually, my problem could have been taken care of by over-the-counter remedy. I just didn't know that. So now that I know that, but 95% of the visit was a lecture on socialized medicine. So that was cool. And it was like 6 doctors standing there because they all had white coats and they all had MD embroidered on it.
And evidently they've got a lot of time.
Yeah, oh yeah, it's the American. Let's talk to her in English. So that was super exciting, but kind of connected to this point. And I want to talk about something that happened that became available to us here in Del Norte as of 2024. So as of midnight, when we were all counting down, adults in California aged 26 to 49 are allowed to qualify for Medi-Cal regardless of their immigration status. So the Affordable Care Act allowed people who were in the country, I guess I'll say legally, and appropriately, I guess, although I still don't like that, to access health care in whatever way they qualified. So income eligible, they could get Medi-Cal. Not income eligible for Medi-Cal could get on the exchange and could get other policies there. Now, what's been added to this is irregardless of their immigration status. So if somebody, crossed the border with a coyote and, is living in Smith River working with the cows right now, they can apply for Medi-Cal. Kind of as appropriate income limits apply, or if they want to actually buy insurance on the exchange, they can.
That's
mixed. Yeah, I know. Some people are going to have mixed feelings about that.
Oh no! And that's my chagrin.
I don't. I'm super happy as a provider to hear that.
Exactly.
So what is commonly the case in the Saturday acute care clinics at Del Norte Community Health Center is that somebody, and I don't ask anybody's immigration status, but a Spanish-speaking individual will come in with a problem that requires more than what I can provide in that situation, and I'll start talking about sending them to the ER because they need this, they need that, and this is the system in this county to get those things, and they never go.
Yeah.
I find out later they never go because they don't have insurance and they're afraid of being, I guess, tagged and then sent back to wherever their country of origin is. But now those people can call 1-800-300-1506, which is the phone number for the exchange, California Insurance Exchange. It's a little maddening, but it's easier to get through if you speak Spanish.
Really?
Yeah.
Good.
It always is. That's why I always hit, I speak Spanish.
Seriously? Really? Why is it? What makes it easier?
Well, there's more people sitting around waiting to help you.
Okay. All right. That makes sense.
Yeah,
okay.
they speak English too. So we can have the conversation in Spanish if they want, or we can have it in English. So, and what I would actually recommend is that they visit patient services at Del Norte Community Health Center. And the phone number there is 707-465-6925. And I have gotten permission from Open Door to start seeing people of migrante status who might need more involved care on the Saturday walk-in clinic. And we also have the advantage of remote translators, and then I also speak Spanish. So this is going to open up labs, imaging, treatments.
Wow.
Like this is amazing.
That is beautiful.
Just amazing.
I had no idea that it happened.
And then they can get them. They have primary care providers who have open panels who are waiting to accept them into their panel. So this is This is healthcare you don't have to cringe at.
Oh my God, that's beautiful.
Yeah, it's super great. And so, the income eligibility still applies, blah, blah, blah. And I guess, you never know what's going to happen in the future. And, maybe you don't want them to have your name. I don't know. Everybody has to consider their particular situation. But this is going to save lives. This is going to save medical dollars.
Wow.
This is a huge, big, enormous thing.
I know, especially up here in our county, in our little red county up here in this little green corner of our state. How in vogue it is always to sort of denigrate California just in general, but that's a beautiful thing. That right there is an example of why I'm happy.
Yeah.
I'm proud to be a Californian.
And I would say before anybody is starting to snort about their tax dollars, they should think about who brought this forward. Who do you think lobbied the government for this change?
Insurance,
hospital,
it's more consumers
California
for them.
Medical Association.
Is this one of those instances, one of those rare instances where capitalism and like humanitarianism sort of kind of dovetail?
Oh my God. This is not the person standing in the corner holding the sign that pisses you off. This is actually government who, in a kind of creepy way, did good.
in a kind of for-profit way, did good. Yeah.
Right.
Interesting, man. I have an insurance-related question for you that kind of fits today's show too. I did not know this was even something my wife told me, looking over, because every year they make you do the insurance dance again, right?
Right.
And so we have to decide, and for a couple of things go into this. So basically, let me take a step back. I got a notice a while ago from Open Door, which is where I've been going, that for the third consecutive visit, I would be assigned a new PCP, like the third one I've gotten. I've gone 3 times and I've had a new person each time. And I'm like, okay, well, all right, whatever. The system should hold, and at least, everything's all there. And I like going to Open Door and all of that. Lisa told me that, my wife told me that according to our Obamacare, that we could actually go to Redwood Medical or one of the private practices too, that they're in the net, that they're covered by the ACA stuff here in town. And so I was wondering, I would. What?
Yeah, I have a comment on that.
Go ahead.
Are you ready?
Yeah.
So yes, the insurance company says you can go there, but
not
if you called
necessarily.
there, they would say that the practice is closed.
Oh, so they're not accepting new, because according to the insurance, they're on it, but they might not be accepting new.
No,
new
insurance
patients.
reality is not on the ground. Boots on the
Right.
ground kind of reality. It's like wishful thinking.
Okay. Well, that's good to know, and that may completely obviate my question then, which is, if given a choice between going to a private practice here or staying in Open Door, which would you recommend?
Oh, I'm a clinic.
You're a clinic,
patient.
yeah. That's what I thought.
I go to whatever clinic is, partially because I work there, and I have like unofficial ways of getting things done, but also I really like the care that clinics give, and clinics don't retire.
Yeah.
Not necessarily throwing shade on Redwood Family Practice.
No, but they exist in a different sort of institutional space.
Yeah, let's say everybody there decided to retire. I have no knowledge about what their plans are, but it's hard to sell a practice. This happened actually for Pacific Vision. Those 2 physicians, Dr. Sink and Dr. Ettinger, wanted to retire, and they had their practice for sale for multiple years. And
Was it? I did not know.
Takers.
And now we don't have an eye doctor in town anymore because of that.
And that's a huge big deal. It's been a terrible thing for a patient of mine this week. Actually, it comes up constantly that it's a problem. But I think you have to look at longevity of practice, especially if you're a younger person. And I think regular private practices are becoming archaic.
Should I be? Yeah, exactly. That's another.
Right.
Should I be concerned about the parade of new physicians that I get at
I think
Open Door?
most of them. No, I don't think you should be concerned about it. But I do think they're mostly nurse practitioners and PAs. There's very few new physicians that actually come in. This whole county is kind of run.
I know, but
NPPA.
in the rest of the world, they say, primary care physician, but
Yeah.
that doesn't necessarily.
Oh, okay.
Yeah, that's
so
why
if we ignore that, I think what's happening is that people come up here because they can pay off their student loans. A nurse practitioner, to get a doctorate degree, is $250,000. You make less money than the average PA, in my understanding.
Wow.
Okay, but not a lot less.
Yeah.
And you have a huge, bigger debt.
Mm-hmm.
So, these newbies come out of school, and that there's a good thing about that. They're never going to be like more up to date with stuff than they are at that
true.
moment.
Right.
But they don't have any maybe seasoned clinical knowledge, and that's, anyway, it depends what you prefer in a provider. And then they hang out for 2 years, their loans are paid, and they shuffle off to Buffalo or something.
Right.
I don't know where they go. But
Wherever
there are very
nurse
few of them
practitioners go.
that choose to hang around.
Yeah.
And it's not because there's no shopping here. It's because there's no eye doctor here.
Yeah.
It's for a while there was no orthopedist. All summer we had no orthopedist. There's nobody that you can get on the phone to get some quick advice from,
Right.
because everybody's so busy that they don't do that anymore. Maybe there's not a professional job for your spouse. So there's a lot to consider.
Okay. And of course, for me, it might just be a moot point anyway. All right.
Yeah, I'd stick with the clinic.
Okay,
The clinic
okay.
is going to be there forever.
Yeah.
Yeah, just
cool.
in reincarnations every 2 years.
Every 2 years. Every time I decide to go back to the. Who are you? All right, Lynn. Well, thank you so very much. Any insights as to the next Health Matters?
No, I haven't really thought about it. Something will come up.
Yeah.
This week there'll be some clinical oddity.
Okay. All right. Thanks. Well, that's wonderful. We will talk again this next week. Thank you, Lynn.
Sure.